All right, well, welcome back everyone. Today we're going to talk a little bit about sodium disorders and specifically SIADH. Of all of the sodium disorders, hypovolemic, hypervolemic, euvolemic, obviously talking about a hypoosmolar state here, SIADH seems to be the one that gives, I think, most people the most trouble in kind of understanding, okay? So before we do that, let's do a little bit of very brief sodium physiology, okay? So when we talk about total body water is about 50% or so females, and it's about 60% in males, okay? So it's a little different proportions. But total body water is really split up into two different sections. Your extracellular fluid and your intracellular fluid. Now, your extracellular fluid is about 1/3 of the total body water. That's why it has a little bit of a smaller area here. Your intracellular fluid is about 2/3 of this total body water, okay? Now, the major cation in the extracellular fluid is sodium. Makes sense, right? The major anions are chloride and bicarbonate. In the intracellular fluid, the major cation is potassium, and the major anion is phosphate, okay? Now, you have a cell membrane here, and water is going to flow across this cell membrane in response to tonicity, or the effective osmolality, okay? And you also have a sodium-potassium ATPase, which keeps the sodium and the potassium in your extracellular fluid and potassium in your intracellular fluid. Your extracellular fluid is split up into two different compartments as well. You have your intravascular space, which is about 1/4 of that extracellular fluid. And you have your interstitium, which is about 3/4. And movement here is based on your Starling forces, okay? So this is your basic outline of total body water, where your sodium is, where your potassium is, etc. Now, when we attempt to understand sodium disorders, the first thing I want us to understand is that plasma sodium does not reflect total body sodium. Plasma sodium does not equal total body sodium. Total body sodium really is reflective of your extracellular fluid volume. Extracellular fluid volume, okay? Because don't you know, if you're hyponatremic, that doesn't always mean that you have a total body sodium is low. Think about your heart failure patients, where you're hyponatremic, but your actually total body sodium is up, your extracellular fluid volume is up, right? So what plasma sodium tells us is that there's abnormal renal water regulation. That's what plasma sodium tells us, that there's abnormal water regulation, okay? Now, let's talk about SIADH and see how this kind of fits in with that brief introduction. So SIADH, the first thing we have to be able to do is diagnose SIADH, okay? So when I see somebody coming from the emergency department and they have low sodium, and I'm not really talking about a sodium of 133, I'm talking about actually a low sodium, you know, in the 120s or so, and for our conversation here, the patient's not going to be seizing, which we want to give hypertonic saline immediately, even before we know what the cause is my standard workup for hyponatremia is going to look like this. And I do this right when I admit the patient, sometimes even before I actually see the patient, because I'm going to get an H&P, right? I'm going to get a HPI, and it's going to bring me closer to that diagnosis, but I want these labs pending and ordered right away. So you already have a plasma sodium, right? It comes in your BMR. So I like to get a urine sodium. I like to get a urine osmolality. I like to get a urine potassium. This is one that I don't see a lot of people getting, but I'll share with you why it's important. I like to get a uric acid level. And if it's not done, it usually is in the emergency department, I like to get a urinalysis. Because this urinalysis, I can look at something right away, and that's the specific gravity. And the specific gravity, what that does is it tells me the concentrating ability of my kidney. So the number that I want you to remember is 1010, 1.010. If I have a specific gravity that's over 1010, that means the concentrating of my kidney is intact. That my kidney is concentrating that, okay? Now, this by itself does not tell me the difference between a hypovolemic hyponatremia, like I'm actually volume depleted, I've got lots of nausea, vomiting, diarrhea, because we know that in SIADH, this is going to be high, the specific gravity, because I'm pulling water in, but it's also going to be high in a hypovolemic state as well. But what this does is it tells me if it's lower than this, then my urine is actually dilute, and I got to think about a different cause. Maybe the patient's drinking way too much water, right? Maybe there's psychogenic polydipsia going on. Maybe it's a tea and toast diet that's accounting for the low sodium. Uric acid, we'll kind of get to that in a second. Urine sodium and urine potassium, I'll show you all that, and a urine osmosis. Usually this is over 300 in settings of SIADH. Remember, in SIADH, from whatever the cause is, you're trying to pull in water. The kidneys are pulling in water inappropriately for this, okay? The other things you want to be mindful of are TSH and a cortisol level, okay? Because if you have adrenal insufficiency of any cause, then that can create hyponatremia. It doesn't matter if it's primary or secondary, cortisol inhibits ADH release. So if I have low cortisol, then ADH, there's no checkpoint for that, one of the checkpoints. And a TSH, really severe hypothyroid, can cause low sodium levels, and you would be in a euvolemic state, okay? So urine sodium in settings of SIADH are typically over 40. And the reason why is, remember, in SIADH, I'm euvolemic, okay? By definition, and what I want you to remember is that the patient is really, it's not hypovolemic. If you were hypovolemic, the natural response is to increase your ADH level. So that's an appropriate ADH response. That's why treating somebody whose low sodium level is caused by vomiting or diarrhea is very easy. I just give saline, and saline will shut off that ADH because it's appropriate. But in SIADH, it's inappropriate. And so I'm pulling in my water from my kidney, and so my urine sodium is going to be elevated. Whereas if this was hypovolemic hyponatremia, this urine sodium would be under 20. Urine osmosis we talked about. Urine potassium, I'll share with you when we talk about treatment. And then uric acid, in a hypovolemic state, uric acid tends to run on the higher side. And in a SIADH or a dilutional component, uric acid is usually normal or low. And so it's not a diagnostic tool, a pure diagnostic tool. You have to actually use it in conjunction with your H&P and with your other urine studies. Okay? So let's pretend now we've diagnosed SIADH. This person has SIADH because they've got euvolemic state going on. They're not volume down, they're not volume up. Their HPI suggests that they're not thirsty, that they haven't been having lots of diarrhea or vomiting. Our urine sodium's high, our urine osmolality is high, our specific gravity is high, our uric acid is low. So now what do? Right? We're on the wards and we've got to treat it. So you're going to diagnose SIADH and you're going to present this to your senior resident or to your attending. My plan, all right? And again, this is for somebody that is not seizing, okay? We always want to give hypertonic saline to those patients in an immediate state. So what's your plan for treating SIADH? Now, if you're listening to this, you're probably thinking fluid restriction. That's the first thing that we want to do. And you are absolutely wrong. That's the second thing that we want to do. Fluid restrict is second. The first thing that you want to do is always you want to find the cause. And you're probably thinking, oh, of course, duh, why are you saying that? It goes without saying, but it doesn't. Because we commonly will go straight to fluid restrict and not think about what is the underlying cause of this. Because I can treat, but if I haven't fixed what's going on, you're going to be you're running in a circle. So find and treat the cause if you can. Now there are many causes of SIADH. I'll just name a few here. Medications. You can ask a pharmacy to run a review of medications. SSRIs are a very common cause of them, I will say. But always think about medications. Infections can cause an SIADH picture, right? Maybe you have a pulmonary infection. Maybe you have a central nervous system infection. They can all cause it. Things like pain, right? We see a lot of patients in the hospital with pain. Pain is a potent stimulator of ADH, so can we control the pain a little bit better? Vomiting is actually, nausea and vomiting is actually a stimulator of ADH. So you always want to think about that as well. So think about the cause before you go down a rabbit hole of just trying to treat. All right, the second thing then is we said we wanted to fluid restrict. And the reason why is we need to lead to a net negative water balance, right? Remember, SIADH, it's a water problem. It's not a salt problem, okay? Your body has two mechanisms in place for dealing with water and for salt. And this makes sense because if you were to go to a pub and eat a lot of pretzels, there's a lot of salt in that. And your body has to be able to get rid of that salt if there's no water. Alternatively, if you were to go to this same pub and drink a lot of water but no salt, your body has to be able to get rid of that water. So the ADH is what deals with water in our body, and the renin-angiotensin-aldosterone system is what deals with salt in our body. Okay? So fluid restrict, because we want to lead to a net negative water balance. So I will typically go somewhere between 800 cc's to 1 liter per day of a water restriction. And that really is a great starting point for that. Okay? Now, I shared with you this urine potassium. Why do we get that? Because when you fluid restrict somebody, you can do a very quick and easy calculation of, is this patient going to respond simply to fluid restriction alone? And it's called the urine cation to the serum cation ratio. So my urine cation, urine sodium plus urine potassium to serum cation ratio. So urine sodium plus urine potassium, and that's over my serum sodium. Okay? If that ratio is under 0.5, I have a good chance that I can correct my sodium just with a fluid restriction alone if the cause is truly all SIADH. If it's over 1, chances are I'm not going to be able to correct my serum sodium just by fluid restriction alone. And this makes sense if you look at this equation, because if my ratio is under 0.5, then there's really not a whole lot of ADH going on, right? I'm not too concentrated in my urine. Whereas if this ratio is over 1, my urine is really concentrated. So something is really bringing a lot of water in. So this is a really easy, quick and way to do it. So that's why you want to get your urine potassium ordered immediately. All right, so the third step, we're going to say fluid restriction to 800 cc's to 1 liter per day, but you've done your urine cation to serum cation ratio and it's over 1, and I get that there's a long range in here. This is why it's just a quick and dirty way to do this. Is I can actually add some solute, right? I'm leading to a net negative water balance, so now I can just do salt tabs. Why don't I just give you some solute, right? What you want to remember is 3 grams TID of salt tabs is equivalent to about 1 liter of normal saline in terms of solute content. The only difference between these is that in 1 liter of normal saline, you actually have water along with it, right? And we said that this was a water problem. So the salt tabs don't have any water in it. The salt content, the solute content of normal saline is 154 milliequivalents of sodium and 154 milliequivalents of chloride, just FYI. If you're thinking about lactated ringer, it's 130 milliequivalents of sodium, 109 of chloride, and about 4 milliequivalents of potassium that's in there. So you don't have to start with 3 grams TID. This is just your reference that 3 grams TID is equivalent to about 1 liter of normal saline. You can start with 2 grams TID. You can start with 1 gram. I typically actually start more on the higher side and then I taper down as I am correcting the patient's underlying cause of SIADH. The fourth thing that we could do is give Lasix or furosemide. Now, think about this. Why do we give furosemide? Well, furosemide is a water pill, right? Here in the hospital, I would typically give it IV, okay? So I would start off with something like 20 milligrams IV once or twice a day in conjunction with my salt tabs. Remember, this is stepwise. So we're going down. We wouldn't just start here. You start here and then go down. So furosemide is it's a water pill, right? It's a water pill. And so your kidney concentrates the urine in where the loop is, right? And so if the furosemide or the loop diuretic inhibits the concentrating ability of your kidney. Let me say that again. Furosemide inhibits the concentrating ability of your kidney, okay? So is my urine in SIADH concentrated or dilute? Well, it's concentrated, right? I'm trying to dilute my urine because if I can dilute my urine, then I know that I'll pee out free water and my sodium in my serum will rise. So this is why you have a grandpa that says, hey, you're a doctor, I have this water pill, can I ask you about it? Right? They don't say it's a salt pill, it's a water pill. So you want to excrete that free water. Now, furosemide, I kind of have a quick and dirty way of when I use it, and it's if my urine osmolality is over 500 or 2 times my plasma osmolality. I would give that right away with salt tabs. So if my urine osmolality is over 500 or my urine osmolality is 2 times my plasma osmolality, I would start furosemide, 20 milligrams IV once or twice a day with salt tabs. Remember, these are just guidelines, okay? These is just this kind of a reference. Every patient is going to be a little bit different, but this is just a quick and dirty way of saying when I would start something. Your plasma osmolality, just to remember, it's 2 times your sodium plus your glucose over 18 plus your BUN over 3, okay? So you can do that, you know, at any point. You don't have to order a plasma osmolality. You can just calculate that, okay? The fifth thing that you could do, and we don't really come to this a whole lot, is you can give a Vaptan. So Vaptan, this is something like Conivaptan or Tolvaptan. Tolvaptan is the oral form. So these are ADH receptor antagonists, so they promote the excretion of free water. And again, that's what we're trying to do, right? We're trying to excrete free water in SIADH. We usually don't use these unless nephrology is involved in this. These actually will increase our thirst. Patients who have underlying liver disease don't do well with these, so it's contraindicated for those. But these are approved for things like SIADH and the edema forming states. So that would be our fifth one that we would go with, okay? So if I was presenting this, and that's it. That's all you need to know about SIADH, okay? That's how you treat SIADH. So if I was presenting this on wards, what I would say was, this patient has SIADH. My first thing that I want to do for this is I want to find the underlying cause. I'm then going to fluid restrict this patient to 800 cc's to a liter per day. Based on my calculation of the urine cation to serum cation ratio, I know this patient is going to need a little bit more treatment, so I'm going to start salt tabs. And based on my urine osmolality, I may or may not want to give furosemide. That's it. That's a really nice, thorough plan for somebody with SIADH, okay? So you've got the 5 steps, and remember, SIADH is not a salt problem, it's a water problem. So fix that underlying problem, and you'll be able to correct your SIADH. All right? All right, thanks guys.